Hi, I'm Tamara Paget, and this week we'll be going over case study 69, premenstrual syndrome. PE is a 34-year-old white female. She is college educated. She's had a 3-month history of premenstrual syndrome symptoms, including irritability and breast tenderness, craving salty foods. Her symptoms have been recurrent and predictable for the last 3 months. These have occurred during the entire week prior to menses. Invariably, these symptoms resolve approximately 2 days after her menstrual flow has begun. And she states that she has not been bothered by these symptoms in the remainder of the menstrual cycle. So they're lasting for approximately 9 to 16 days, the week to 2 weeks before in the luteal phase of the menstrual cycle. Her menstrual cycle has been very predictable, between 27 and 28 days apart for the last 2 years. Her OBGYN recommended her to come to the premenstrual syndrome clinic from a traditional annual well exam where she brought up these concerns. Premenstrual syndrome is a recurrent cluster of over 200 symptoms. These symptoms are both physiological and emotional or psychological. There can be depression, anxiety, mood swings, anger, irritability, insomnia, and poor concentration. And the most common physical symptoms can include tender and swollen breast, abdominal bloating, abdominal pain, fatigue, joint and muscle pain, and headaches. Risk factor for PMS include a personal or family history of major mood disorder like depression, certain personality characteristics like perfectionism, poor nutrition, especially lack of dietary vitamins and minerals, lack of exercise, low self-esteem, history of sexual abuse or domestic violence, and a predisposition to PMS does run in families. So there is perhaps a genetic factor or shared experiences that has not been determined yet. Also, women's menstrual experience tends to be similar to that of their mothers or sisters. The cause of PMS is this fluctuating hormones of progesterone and estrogen. These symptoms do resolve during pregnancy and after menopause, and sometimes these can be self-treated. But if unable to self-treat, SSRIs can be taken just during the days of symptoms or continuously every day if more severe symptoms persist. This PMS differs from PMDD, which is a severe form of PMS that cannot be self-treated. This has to be treated by a physician, and about 75 to 85% of women have PMS, and about 3 to 8% have PMDD. And I'm sorry, this PMDD has to be treated by a provider, not necessarily a physician. And the only way that PMS completely resolves is with the removal of the uterus and ovaries or in menopause. The pathophysiology of PMS, there's an exaggerated tissue response to the hormonal changes, like we talked in the last slide with the estrogen and progesterone. The SSRIs can decrease symptoms, which shows that PMS is a disorder of a decreased level of serotonin within the nerve synapses. There's been several theories on PMS, but no concrete reasoning behind why this fluctuation of hormones causes such a wide variety of symptoms and why this hormone fluctuation affects women differently. There are really no laboratory tests, but according to the American College of Obstetrics and Gynecology, a patient can be diagnosed with PMS if the symptoms are recurrent only during the 2 weeks before the onset of menses. Symptoms impair quality of life to some degree, and a medical condition that can cause these symptoms has been ruled out. That would be things like hypothyroidism or other reasons why a woman might be having these symptoms. This patient's clinical manifestations of PMS include breast tenderness, irritability, and salty food cravings, which she does not usually have. She has her history, reported history is that her father, who is 61, has high cholesterol, hypertension, cardiovascular disease, glaucoma, and colonic polyps. Also, her mother had PMDD, which resolved when she became menopausal at the age of 44. And she has one sister, 30, that has PMS. Her physical exam is unremarkable. She just had her pap and mammogram, which were normal. All her labs, including a CBC, THS, and glucose levels, were normal, but there were no other labs obtained, which means that there could possibly be some other underlying reason for this, but probably not. Her vital signs and BMI are all within normal range. The role of the APRN will be to help this patient set some realistic expectations that the only way to fully treat all symptoms of PMS is with the onset of menopause or with a hysterectomy, but that the symptoms management can be obtained through either medication management with SSRIs, diuretics, or holistic management with exercise, dietary changes. And to be a prayerful support system for this patient, including psychological supports, maybe helping with stress relieving or suggesting counseling, but to really make sure that you're offering prayer and godly advice if this patient is open to that. And questions for review. What medications could a person diagnosed with PMS take to help manage symptoms? We have already talked about an SSRI, but there are some particular ones that are usually prescribed. And what are the main diagnostic differences between PMS and PMDD? What are the dietary changes that can be recommended to a patient with PMS, and why? Why do these dietary changes really help patients with PMS? And here are my references for your review. I hope that you have learned something and been interested in this presentation. Have a great day.